Welcome, everybody. Today's special lecture is on long COVID, ME/CFS, and FM in children and teens. I'm Ric Arseneau. I am the one of the founders and the medical director of the BC Center for Long COVID, ME/CFS, FM. I'm also a clinical professor in the Division of General Internal Medicine in St. Paul's Hospital in the University of British Columbia. So a little bit about our clinic before we start. We have well over 6,000 patients, almost 7,000 now, and we have a clinic that provides ongoing care, which means that once you're referred to us, we don't discharge you unless you want to be discharged. It's a virtual group-based model of care, and patients can participate as soon as they're referred. So unlike other clinics where you have to wait to see the physician before you can participate, and sometimes that can be as long as 3 years, you get referred today, you can participate later today or tomorrow. And so our program includes an individual consultation. And right now, to see me, it takes about 15 months. But for the pediatric patients, I'm not a pediatrician. So the irony that I'm presenting about children and teens. Dr. Lana Diamond is our family physician with an interest in this area. And like many of the physicians or the people who run our groups, she's also a patient in remission. So after the individual consultation and even before the individual consultation, patients are able to see the physician in group medical visits. And this is really group medical follow-up. It's 10 to 12 patients for 1 hour. And if we can't deal with the issue in the group, we book an individual visit. We also have group medication visits, up to 50 patients for an hour. And then we have our groups themselves. We have 40 different groups led by physicians, occupational therapists, physiotherapists, dietitian, counselors, psychologists, naturopath, and others. The groups are anywhere between 4 weeks and 6 months long, and most of them are less than 10 weeks. We also have weekly lectures like this that are either a one-off or that are recurring. And the recurring ones tend to be the occupational therapy, physiotherapy, the dietitian, and the naturopath. So when I was in medical school, one of the things that they emphasized was that children are not small adults. And so that what you learn about adults may not necessarily apply to children. Luckily, we have an excellent team that will be able to look after the children. We have Dr. Lana Diamond, who I've already talked about, Dr. Lucia Ma, who is an expert in hypermobility, in mast cell activation syndrome and postural orthostatic tachycardia, Judith Orban, a physiotherapist with expertise in hypermobility, and Dr. Angela Grace, a PhD psychologist with expertise in working with children and long COVID. So at the beginning of the pandemic, my partner and I were in Mexico, and the pandemic was announced. And the first thing I said is, uh-oh, we're going to see a lot of patients come, because we know that about 10% of patients who develop an infection go on to develop the post-viral syndrome. So my colleagues and I were highly confused when we heard on the news or read in the newspaper, what is this long COVID? What is happening to these patients? Well, it's clear they have a post-viral syndrome. And how did we know this? Because this is only one of many studies that looks at what happens to people after they get an infection. And this one is the Dubbo study, probably the most famous, that comes out of Australia. And what they found is that people who came to their infectious disease clinic, that at 6 months, about 11% of them fulfilled criteria for chronic fatigue syndrome, also known as myalgic encephalomyelitis. And this was consistent across infections. It didn't matter what infection you got. So they postulated that it was related to the host response rather than the specific thing that causes the infection. And that's why we can see it not only after viral infections, but after any kind of infections. So these, within about a year or so, our predictions came true. And so you can see I was pretty close, right? 10%, it's just over 10%. So it's somewhere between 10 and 11%. And that was the original strain. The good news is that as the strain has evolved, the chances of developing long COVID are now just under 8%. And keep in mind that this is adults. The thing that people don't realize often about vaccination is the vaccine is really promoted to prevent hospitalization and to promote death. Nobody talks about the fact that it prevents long COVID. So you can see that even today, if you're vaccinated, your chances of long COVID when you get COVID are reduced by half. So that's why we have a big emphasis on promoting vaccination. So let's look at some myths and facts, because one of the things you're going to hear is that, oh, long COVID doesn't really do anything in kids. It causes minimal impact. So here's some data. It's a little bit older. Newer data is not available, but it's from the NCHS, which is part of the CDC in the United States. And here they put kids who have ever had long COVID. And we'll see how that information is not likely reliable. But current long COVID means those who continue to have it, because some of these people may have gotten better, and we'll talk about that. But you can see that the risk of long COVID increases with age. And so kids under 5, 0.2%, kids under 11, 0.3%, and 12 to 17, 0.8. So they say, oh, that's a really small number compared to the 10% that you showed us earlier. Well, keep in mind the 10% that I showed you earlier was of people who got COVID. This is of the entire population. And so the number looks small, but when you multiply it by the number of kids in the US, it's 5.8 million children and adolescents with long COVID. That's a bigger burden of disease than asthma. And based on quality of life scores, it's causes more disability than cystic fibrosis and cancer in children. So what's the problem in terms of getting a diagnosis for your child? Well, the problem is that these conditions are confusing, and we'll see that. The first thing is that what are the symptoms? So there are over 200 symptoms that have been described in these conditions. But those of us who see patients often know that if you look at the forest and not the trees, that you can categorize these symptoms into 5 categories: fatigue, pain, sleep disturbance, and brain fog. The other one is unexplained symptoms. And the unexplained symptoms are you went to the doctor, they can't find anything wrong. And the most common are the gut, the brain, and the autonomic nervous system, so the adrenaline system of the brain. But it can be any system in the body. Those are just the most common. To further complicate things, most patients who come to our clinic as adults, the fibromyalgia, the chronic fatigue syndrome, does not occur in isolation. It's part of a family called central sensitivity syndromes. It's important to note that CSS, central sensitivity syndrome, with an S, syndromes, is not a separate syndrome. What it is a family name for conditions that run together. And you can see the list here: ME, FM, and myofascial pain, migraines, tension headaches, IBS, POTS, which is posture orthostatic tachycardia syndrome, interstitial cystitis, pelvic pain, and others. And so in our clinic, the average that I see is 5 or 6. The range is occasionally we see a patient with 1, not very often. And the most I've ever seen is two patients who've had 14 of these conditions. So when you review the literature for kids, the number is between 3 and 6 of these central sensitivity syndromes. Huh. So in this case, actually, kids are like adults. And so you can expect that your child will have at least one and likely more than that other central sensitivity syndromes to confuse the picture. One of my patients said, "Why are you giving me this alphabet soup of acronyms? I'm not trying to collect diagnoses." So what I told them is that each one of those acronyms, each one of those diagnoses is a lever that we can press on to try and improve symptoms. And so it's how we generate the plan. So let's get back to the name of long COVID. I was surprised when it got a name. I was actually even more surprised when the name kept changing. Long haul COVID, long COVID, post COVID conditions, post acute sequelae of COVID, and most recently, post acute infection syndromes. And so we take an approach very similar to the Mayo Clinic. Keep in mind that what I'm telling you here is not the right thing. It's one of many opinions about how we should slice this cake. Some people say it's a cake, you don't slice it. The Mayo Clinic says that post-acute sequelae of COVID or post-COVID conditions is 3 groups. The first group are those who get tissue damage like lung scarring, heart inflammation, loss of smell. Then you have the people with no identifiable tissue damage, the people where all the tests come back normal. And they say those people have a post-viral syndrome, most likely chronic fatigue syndrome, ME, but it can be any central sensitivity syndrome. They also say some patients are going to present with psychiatric and psychological conditions. So the Mayo Clinic says this is long COVID, and post-COVID and long COVID are 2 separate things. We've expanded that a little bit. And so we think that post-COVID conditions, or PASC, should be differentiated by the type of problem COVID causes. So the first is tissue damage. So you get acute infection and the virus can damage your lungs. You can get lung scarring, can cause inflammation. You get a blood clot. You can lose your taste or smell. You could get inflammation of the heart. The second is viruses can trigger autoimmune diseases. So some of the post-COVID conditions include triggering of rheumatoid arthritis, lupus, inflammatory bowel disease, Sjogren's, alopecia, hair loss, vitiligo, loss of pigmentation. The third category is that COVID can trigger or accelerate metabolic disorders. So it can cause new diabetes, new hypertension, new high cholesterol. It can also accelerate these. So if you have these conditions, COVID can drive them so that you get to a heart attack and a stroke earlier. We've already talked about the psychological, psychiatric, described by the Mayo Clinic, depression, anxiety, and PTSD. And then we have the post-viral syndromes. So to us, the baby finger is long COVID. To many others, it's all the hand. But we think the hand is post-COVID conditions. Doesn't matter who you believe or who you think is right. What's important here is that you recognize that there are different things that can happen. And you can imagine if you put this whole mess of different patients in a study, nothing is going to work in terms of treatment, and nothing is going to be found as a biomarker because they're all different conditions. And so to show you how bad it is, this is what doctors use when they want to find research papers. And you can see here I've typed in long COVID. The system is set up to what are called mesh subheadings. So, for instance, if somebody were to type in atherosclerotic heart disease or coronary artery disease or atherosclerosis, it would map to one thing. So when I typed in long COVID, it actually mapped to post-acute sequelae of COVID or post-COVID conditions. Here they even gave it a different name, post-acute COVID syndrome. So what that means is that when the medical literature is cataloging research, they do not make a distinction between the post-viral syndrome and all the things that can happen after COVID. So here's an example that happened a few years ago. All my patients are coming to group medical visits and they're saying, do I have microclots? Because here it says in patients with long COVID, post-acute sequelae of COVID. So this is the hand. This is not the baby finger. So what this means is that we don't have a clue. Because is it the patients who had inflammation who had the microclots? Is it the patients who had the post-viral syndrome? Is it the patients who had the metabolic disorders? Who knows? This is a slide from a presentation last week from the Long COVID Society of Canada, the COVID Society of Canada. They had a pediatrician researcher from the United States come and talk about long COVID. And so he's talking about a treatment in kids, but you'll see over here it says augmented recovery in children with post-COVID multisystem inflammatory syndrome. So they've even invented another name, what to call it. So this likely does not apply to many of the patients who are post-COVID and none of the patients who are long COVID, because these are the patients who get inflammation. Are you confused enough as it is? It gets worse. So there are all these symptoms that can present. And so we're looking for a definition. And the problem is right now, people are fighting for how long you have to have symptoms before it counts as long COVID. That's the wrong approach. The approach should be based on what kind of problem did COVID cause? And so this is what the pediatrician presented, and it's symptoms that continue after 3 months. And if you go to the World Health Organization, it's the same definition. So it's time-based. And the problem with making it 3 months is that anything that you look at for prognosis is probably irrelevant because the earlier you go to call it long COVID, the more people are going to get better. And so it's not a good predictor if you have long COVID or post COVID of if you're likely to get better because they've included way too many people who were early and were likely going to get better anyway. So the prognosis is irrelevant. The other thing, and this is a very well-respected colleague of mine, she was interviewed last week, and she was talking about long COVID and saying that there's a study to show that how severe your COVID infection is a good predictor of whether you will develop long COVID. Yes, if long COVID is the hand, no, if long COVID is the baby finger. Because, of course, if you have an acute infection requiring hospitalization or the intensive care unit, you're going to be more likely to have blood clots and inflammation and heart damage. But I can tell you, out of the patients in our clinic, we only have a handful who are even hospitalized. So the post-viral version of this, what we call long COVID, the severity of the acute illness determines nothing. It tells you nothing about the risk. And so let me give you an example of how this plays out in policy and politics. The post-COVID clinic in British Columbia, at some point when they were overwhelmed, they only saw patients who were hospitalized, which means they were only seeing the thumb and the first three fingers. They were not seeing any patients with long COVID, the post-viral syndromes. So, all of this to say that our clinic defines long COVID as a post-viral syndrome. And the problem with any syndrome is you're either in or you're out, which means you either have it or you don't. And that's not reality. The reality is you could have a mild version all the way to a severe version. The mild version, everybody is familiar with. Those are the young adults who get mono and are out of commission for 6 months to a year and bounce back completely. The people who are in the middle are like me. I have about a 50 to 60, depending on the day, maybe 70% capacity before I got COVID. And I've also got severe orthostatic intolerance, which means I get very dizzy when I stand up. But I don't fulfill criteria for POTS and I don't fulfill criteria for chronic fatigue. So I'm somewhere in the middle. So depending on how many of these people you include in determining the prognosis, the people who are here are going to have a different prognosis than the people who are here than the people who are here. So that begs the question, are long COVID and chronic fatigue the same thing? Well, no, because chronic fatigue syndrome has many triggers. It can be a physical trigger like a car accident, it can be a psychological trigger like PTSD, and it can be an infectious trigger of which viruses are only one cause. And so the other problem is that post-viral syndromes include not only chronic fatigue syndrome, but they include fibromyalgia, postural orthostatic tachycardia syndrome, mast cell activation syndrome, irritable bowel syndrome, migraines, and often some of the other central sensitivity syndromes. So if we look at how we slice it, that post-viral syndromes can be a whole bunch of things. And chronic fatigue syndrome has a lot of triggers, of which post-viral is only one part. So if we look at long COVID's overlap with chronic fatigue syndrome, what we can say about the relationship is that many, probably most patients who have the post-viral syndrome will have ME, but many of them will have instead fibromyalgia, POTS, MCAS, or others. Now you can see why it's so confusing. So coming back to our tree versus forest, we're looking for fatigue, pain, brain fog, sleep, and unexplained symptoms. So let's have a closer look at some of these post-viral syndromes and one associated condition, hypermobility. We're going to start with ME, chronic fatigue syndrome. And so we know that there's a genetic predisposition. We have a lot of patients who have family members. That's why right now our clinic is seeing mostly the children or the grandchildren or the nieces, nephews, relatives that are children or teens for patients who are already in our clinic. The other predisposing factor is adverse childhood events or trauma. So coming back to the kids, in my practice, most of what I've learned has come from listening to over 10,000 patients. And one story that I hear constantly is when I was a kid, I had growing pains. When I had a kid, they worked me up and they couldn't find out why I had abdominal pain. When I was a kid, I had lots of headaches. I had constipation that was almost impossible to treat. And so I looked for any evidence that these were predictors of developing chronic fatigue, fibromyalgia, post-viral syndromes later in adulthood. And the result was that there's moderate evidence that childhood recurrent abdominal pain, headaches, or a high burden of somatic symptoms. I hate the word somatic, but it basically means we can't find anything when you have a symptom. The other thing is I that I wondered was if you have a pre-existing central sensitivity syndrome, like migraines or IBS, are you more likely to develop a post-viral syndrome? I have not seen much research on that, but I can tell you in our clinic, that's definitely the case. And that pre-existing central sensitivity syndromes, there is, again, moderate evidence for kids. The growing pains and the recurrent musculoskeletal pain also had moderate evidence. And so it means that my patients are usually right, and they tell me what I'm going to find in the literature before I even see it. So let's talk about the fatigue itself. And so the thing about fatigue is that the fatigue of chronic fatigue syndrome is not the same. It's unexplained. It does not improve with rest. And most importantly, it's associated with post-exertional malaise, what patients will call a crash. The problem with the word post-exertional malaise is that it's neither exertional nor malaise. In fact, most of my doctor colleagues and my doctor students, when they see post-exertional malaise, their brain substitutes the word exercise. But exertion can be brushing your teeth and showering on the same day. So post-exertional malaise is the pathognomonic symptom of ME/CFS. And pathognomonic is a fancy word that means only seen in chronic fatigue syndrome, not other conditions. So it's exertion, not exercise. But our patients often use the word PEM, P-E-M, for post-exertional malaise. And I jokingly say, well, it should be PEMAWAS because it's post-exertional malaise and worsening of symptoms. In fact, the Bateman Horne Center in the United States, instead of using PEM or post-exertional malaise, they use post-exertional symptom exacerbation because it can be any symptom, not just malaise. So one step better. But the other problem is that it's not just exertion. It's physical exertion, it's cognitive exertion, it's emotion, it's stress, and environmental stimulation. And basically, it's anything that overuses your battery makes your symptom worse. So I'm hoping somebody comes up with a nice, snappy, way to say that because PEM is very confusing, not only to patients, but to doctors. So this is a picture that most of my patients know that I do this as a hand puppet. And I do it as my hand going downwards. And I say, first thing that happens is no physical life. I get worse. No social life. I get worse. I struggle with chores. I get worse. I struggle with self-care. And then finally they stop working. But the idea here is that as long as you push, you're going to continue to get worse. And this is the slide that when I'm talking to doctors that I think is the most important. Because you remember the doctor's dictum is first do no harm. Telling patients to continue to work, telling patients to exercise, telling patients to push through symptoms will only make them worse. So do no harm. So the bottom line is that chronic fatigue syndrome, it's mitochondria, not hypochondria, which is why I hate the word somatic. And how do we know it's mitochondria? It's based on studies that look at oxygen utilization. And so here, what they're going to do is they're going to make this woman run and exhaust herself and see how much oxygen she uses. So this is a study that was done by Stacy Stevens and her colleagues, and it's a bit complicated, so I will walk you slowly through it. But basically, it shows control group. And here the control group wasn't regular people, it was couch potatoes. So they compared couch potatoes to patients with chronic fatigue syndrome. And they looked on day 1 and day 2. And so you can see here that the couch potatoes, if they work out this hard in the blue, they use this much oxygen in the beige. But why this study was so clever is that it repeated the study 2 days in a row. And what it showed was that essentially the couch potatoes can exercise about the same and they can use about the same amount of oxygen. This is the key, is that patients with chronic fatigue, yes, they can exercise less. And this small portion is the deconditioning. In fact, if we compared athletes for the Olympics, we would say they had this much uh, exercise they could do and they could use this much oxygen. It's conditioning. So this little piece is deconditioning. But let's look at what happens to the patients on the second day when they're in post-exertional malaise. They can push themselves, but their ability to use oxygen drops by more than 50%. And so the best comparator for this is, again, the Olympics. How long does a marathon last and how long does a sprint last? Because a sprint uses anaerobic metabolism. That's what our patients can do. They can't do marathon anymore. They go into anaerobic metabolism. They collect lactate, it accumulates in their muscles. So it's mitochondria, not hypochondria. So when we come back to kids, there's actually no pediatric definition that's undergone a formal validation for kids. And many pediatric programs around the world use the same criteria as we use for our adults. So this is another place where kids are going to be the same as the adults. We're going to be able to use the same diagnostic criteria that we use for adults. And so basically, it's all of these things, but it's not just fatigue. It's fatigue, post-exertional malaise, sleep dysfunction, pain, brain fog, autonomic dysfunction. So that's the dizziness, the POTS, the IBS, the nausea, the lightheadedness, the palpitations. It's the neuroendocrine manifestations, the problem regulating your thermostat, sweating, feeling feverish, weight change, loss of appetite, and most importantly, loss of adaptability and worsening of symptoms with stress. And finally, the immune system, enlarged lymph nodes, flu-like symptoms, sensitivities to food, medications, chemicals, sore throats. And to make this even more confusing is that most of our patients have 20 plus symptoms. How many symptoms are you allowed to bring to your family doctor? They're not going to be able to see the forest. If you see a specialist, even worse, they're only interested in symptoms that are in their wheelhouse and don't look at the big picture. So the medical system is inherently set up not to be able to make a diagnosis of these conditions. So mitochondria, fatigue, post-exertional malaise. Let's look at fibromyalgia and central pain. Because when I went to medical school, there was only two types of pain. There was nociceptive pain, which is from inflammation and damage. So inflammation, you can think rheumatoid arthritis, and damage, you can think of osteoarthritis, grinding bone on bone. And we also had neuropathic pain, which means damaged or irritated nerves, like somebody who gets a slipped disc. And I, in medical school, was told that chronic pain does not exist. When I went to court a few years ago, they hired a so-called expert from Toronto to come and say that chronic pain does not exist. Luckily, he was laughed out of court. But now we know that there's a new kind of pain, nociplastic. And nociplastic means that the volume knob is turned on for the pain. So something that should hurt a bit hurts a lot. Basically, central sensitization, not central sensitivity syndromes. Central sensitization can occur in other conditions that are not a central sensitivity syndrome. So, for instance, all chronic pain conditions have a component of central sensitization. And so over the last decade, what we've seen is that medication that is traditionally used for fibromyalgia, the classic central sensitivity syndrome, is used in osteoarthritis because the chronic pain of the grinding bone leads to pain amplification at the level of the brain. And most importantly, a person can have more than one type of pain. So this is the pain curve. And basically, when I go from 0 to 100, it hurts more. This is ouch, this is ouch, ouch, and this is ouch, ouch, ouch. And as I move towards the right, this is how much I'm hurting you. And in the studies, they tend to put a clamp on your hand and they keep squeezing until it hurts. And so I put the clamp on, it doesn't hurt. I put the clamp on it, you don't really feel anything. And then it starts to squeeze, starts to feel uncomfortable. And then you get to the point where it hurts a lot. Patients with chronic pain, they have a shifting of the curve towards the left. And that means that touch, something that shouldn't hurt, can actually cause pain. It also means that the pain is amplified. So here you can see if I'm squeezing you this hard, it should hurt this much. But if you have fibromyalgia or central pain, it hurts this much. And that's called hyperalgesia. Over here, things that should only feel like touch that cause pain are called allodynia. And this can be devastating and debilitating. Some patients have a hard time even having clothing on because it hurts them. So this is the same thing, but with fewer data points. And so again, the scale over here is 0, no pain. This is ouch, ouch, and this is ouch, ouch, ouch. And over here, they can actually tell you, that's actually, you can see the clamp, kilograms per centimeter squared was how tight the clamp was. The squares are patients who are normal, controls, and the triangles are fibromyalgia. So I squeeze the clamp and it hurts this much in a person who doesn't have central pain. But the person with fibromyalgia will feel like it was squeezed this much. And so I love it when I go to court and they say, Doctor, you'll agree with me that there is no way to establish how much pain a patient is feeling. And I go, actually, I do not agree with that. It's just that this test is only available in a research setting. So, getting back to kids, there is a different diagnostic criteria for children. And for some reason, they've decided to call it juvenile primary fibromyalgia syndrome instead of fibromyalgia. It's fibromyalgia. The other thing is that these were developed by consensus, which means it's just 10 guys, 10 gals in a room saying, let's include these. So it was never validated. Also, it included 31 tender points. And anybody who's familiar with fibromyalgia will know that we abandoned tender points in 2010 because they're not reliable. And so here you have a scale that's not valid and not reliable. So what do most pediatrics clinics do? They actually use the same criteria that we use in adults. Huh. So in this case, kids are like adults. And so what it's meant is that when I first thought about offering a pediatric program, I thought we were going to have to relearn everything. But it turns out that most of what we have already, we can translate to kids. So here's the fibromyalgia revised criteria. And so it changed not only in 2010, but in 2011 and in 2016. And this is the most recent. And basically, you need to have widespread pain. They've described widespread pain as 4 out of 5 areas. An area is shoulder, arm, hip, buttock, leg, and neck and back. The front doesn't count. So you get a score for that. You get a score for fatigue, for brain fog, for unrefreshing sleep, for pain in the abdomen, depression, and headaches. Wow, this sounds like chronic fatigue syndrome. Fatigue, pain, sleep disturbance, brain fog, and unexplained symptoms. So what the hell is the difference between chronic fatigue syndrome and fibromyalgia? Ah, chronic fatigue syndrome has post-exertional malaise. Fibromyalgia does not. Chronic fatigue syndrome has pain, but it does not need to be widespread. So what I tell my students is there's two questions you can ask to rule these conditions out. Do you have widespread pain? No, you don't have fibromyalgia. Do you have post-exertional malaise with your fatigue? No, you don't have chronic fatigue syndrome. So it's not just the central pain, it's not just the chronic fatigue syndrome, but both chronic fatigue syndrome are associated with three other things that we see commonly in the clinic: hypermobility, postural orthostatic tachycardia syndrome, and mast cell activation syndrome. There's some studies to suggest that those three occur more likely together, but other people think, well, you just looked at those three, that's why you saw them together. If you substituted migraines or fibromyalgia, you would see just as much. So let's look at POTS, orthostatic intolerance. I mentioned that I have orthostatic intolerance, which means I have a hard time being in the upright position in the afternoon. POTS is a kind of orthostatic intolerance that's due to an increase in heart rate. So patients tend to feel dizzy, but it also makes fatigue worse. It makes brain fog worse. Usually, whenever we talk about POTS, we also talk about low blood pressure. And so orthostatic intolerance occurs in three types. You have patients who have POTS. You have patients who have orthostatic hypotension, which means their blood pressure drops when they stand up. And you have patients like me who have low orthostatic tolerance, which means that there's no change in the heart rate or blood pressure, but you still get about a 20% reduction in blood flow to your brain. So, how do you make a diagnosis? With POTS, it's pretty easy. You lie in bed, then you stand up, and you see what happens to your heart rate. In adults, if it increases by 30 beats or more, you're considered to have POTS. If you're between 12 and 19, it's 40. If you're under 12, nobody has a clue. But doesn't matter which one of these you have. If you have orthostatic intolerance, you'll often benefit from treatment. The orthostatic hypotension, the low blood pressure, those are patients who have a drop in the top number by 20 or more, and the drop in the lower number by 10 or more. So here's a graph. It's a little bit confusing, but I'll walk you through it. So these are healthy controls. And so the healthy controls, when they go from lying to standing, they have a slight reduction in their blood flow to their brain. All patients with chronic fatigue and fibromyalgia, they have a 20 to 25% reduction in blood flow. And that's why if we treat them like they have low blood pressure or like they have POTS, they get better. And you can see here are patients with chronic fatigue with normal blood pressure and heart rate. These are patients with chronic fatigue who have low blood pressure, orthostatic intolerance, and these are patients with chronic fatigue um, who have POTS. So yes, it does get worse. And the problem is that you can have both low blood pressure and POTS at the same time. So POTS is a disease of gravity. And that's why we see it in astronauts when they come back from the space station. And so basically, when you stand up, gravity doesn't send enough blood to your brain. And so what happens is that you pool your blood in your lower body. Normally, your heart will compensate by beating faster. And that's good because you pump more blood. But The faster your heart beats, the less time it has to fill. So each pump has less blood in it. And so at some point, rather than pumping overall more blood, it pumps overall less blood and you get all the symptoms. So most people think that they need a tilt table test, which is a fancy test that is hard to get in British Columbia and that has a lot of false negatives, which means that if you go in the afternoon, your test might be normal, but you still have POTS and you'll be told that you don't have POTS. So what's actually better is what the astronauts use, the NASA lean test. Basically, what you do is you measure your heart rate before you get out of bed, and then you lean against the wall for 10 minutes. If your heart rate increases by 30 beats or more as an adult, and your heart rate increases by 40 beats or more as a 12 to 19-year-old, it's diagnostic for POTS. You don't have to wait 10 minutes. You can sit out. But the definition for POTS says there should not be any significant drop in blood pressure, which means that a lot of patients who go to a neurologist or a cardiologist, the diagnosis gets missed because they don't realize that in our patient population, the low blood pressure can coexist with the POTS. So we have a handout where patients can do this on their own. It explains how to do it. They can record it and they come back to us and they report the results and we can make a diagnosis of POTS. So what about kids? So 70 to 100% of children with chronic fatigue syndrome have significant orthostatic intolerance. So even more than an adult. Diagnosis. Most of what I read said don't over rely on the orthostatic vitals or the tilt. And I think it's because they didn't realize that even if those are normal, that it's worth treating because there's less blood flow to the brain. And so what they said is look for classical position symptom history, which means do they get dizzy or fatigued or worse, brain fog when they stand up for a long time? The prognosis tends to be better in youth. So some kids will grow out of it. And one of my colleagues, a cardiologist, told me that Dr. McKay and I should not be seeing patients with POTS that really, we're not cardiologists. And what I said was, do you know about the association of chronic fatigue syndrome, fibromyalgia, mast cell activation? Do you know about the fact that orthostatic intolerance can coexist? And I said, in my mind, cardiologists should not be seeing these patients because they do not have a broad enough knowledge base. So next, let's look at mast cell activation. So mast cells are the cells that release histamine. And you guys will know them mostly as the allergies. So here's what happens. You have receptors on your cell that say, oh, I don't like peanuts. Whenever you have peanut, when two of these cross over, the mast cells go blah, and they release all kinds of mediators. We think mostly of histamine, but look at all these mediators. The issue, though, is that there's a lot more different things that can trigger mast cells than allergies. And so what our patients have are mast cells that are twitchy, that are bloated. And so they might find that they get triggered by scents, stress, medication, temperature change, by infections, exercise, foods, older teens with their menstruation, and insect bites without actually being allergic. So these are not true allergies. There's lots of symptoms that come from mast cell activation. And it's a bit confusing, especially since a lot of the symptoms overlap with chronic fatigue and fibromyalgia, fatigue, pain, brain fog. So when we screen, we have a screening test. And the reason we screen is because we always treat MCAS first, before POTS, before chronic fatigue, before pain. Because it affects all the symptoms, we want to make sure that we get that first. So here's the screening test. And basically, we try and identify patients who have things like, do you have lung symptoms? Do you have food sensitivities? Do you have sensitivities to medications or chemicals? Do you get hives? Do you have gut issues? But one of the main triggers for the mast cells is a hormone called CRH or CRF, corticotropin releasing hormone. And so if we look at our stress response in the HPA axis, the hypothalamic pituitary axis, CRH sets the body to release the cortisol and the adrenaline that happens in the stress response. But CRH also triggers mast cells, which is why the stress response is one of the biggest triggers for mast cells and why it can be so confusing. The other reason that it can be confusing is that if you go see a allergist immunologist, half of them will tell you that it's not a real thing. That they'll tell you that it's a rare condition. And the reason is because they're looking for mast cell that's due to a condition called mastocytosis, which is a tumor of mast cells, a malignancy. We're not looking for that kind. And so the kind we're looking for does not have the normal lab test for mastocytosis. So the tryptase is normal. Make it even worse, nobody agrees on the criteria. So most clinics like ourselves use a practical approach of what we call a therapeutic trial. We try 3 antihistamines together. If you get better, we say you have MCAS. Combination of a sedating antihistamine, a non-sedating antihistamine, and an H2 blocker, which you guys will think more of a stomach remedy like Pepcid. And patients who have MCAS don't say, oh yeah, it helped a bit. They're going to go anywhere from wow to game changer. And that's why we always look at MCAS first. So again, no consensus, disputed diagnosis, and how we approach it. So what about kids? Parents get told the same thing. MCAS due to mastocytosis is rare. We agree with that, but that doesn't mean that mast cell activation is rare itself. Again, there's minimal literature, so it's even worse in kids. But most clinics that see kids with these conditions use the same approach in adults. And so, for example, the Bateman Horne Center, they use the therapeutic trial of antihistamines like we do, avoid trigger, supplements, and medications. So this is another area where kids are not so different from adults. And finally, let's look at hypermobility. So hypermobility can exist along a spectrum all the way from hypermobile spectrum disorder to hypermobile Ehlers-Danlos syndrome. And these are the kids who are bendy twisty. And you can look at this by the Beighton score so that you can usually bend their finger back to 90 degrees. They can usually touch their thumb to their forearm. Their elbows and their knees bend backwards and they can touch the floor. There's a screening tool here. And the important thing is that our clinic always looks at POTS second. Why? Because lack of blood flow to the brain can cause fatigue and brain fog. So we always treat MCAS first and POTS second. And here's our screening tool. And so hypermobility in adults, depending on the study that you look at, it'll say anywhere from 15% to half, fibromyalgia from 25 to 30%, and long COVID about 30%. So, and these are overlaps. So you could probably guesstimate that a third of the patients we see will be hypermobile. Hypermobility is another orphan condition, not only in British Columbia, but in Canada. And although we have a fantastic program for hypermobility, we have limitations because we will only see you if you have chronic fatigue syndrome, fibromyalgia, or long COVID, which means that all of the other children and adults who have this don't have anywhere to go. If we opened up our doors, our clinic size would double. The same with POTS. There's lots of POTS out there that's unrelated to chronic fatigue, fibromyalgia, but we just don't have the capacity to see everybody. So, what about kids? Again, there's almost no literature in the kids. The important thing is that kids are bendy usually, and that it can be normal to be bendy as a kid and it decreases with age. And so there's likely higher rates of children with hypermobility with CSS than with kids, but the overall meaning is less about being hypermobile, but how severe the hypermobility is. And the one study that I found said about 60% of patients that are children with chronic fatigue syndrome, so pretty close to what we have as adults. So again, kids are not that different than adults. And for those of you who are interested, we have our YouTube channel. There's a special lecture by our physiotherapist Judith Orban on a practical guide for parents. And so you might be saying, why was Rick focusing on kids are not like children, but actually they're not that different? Because it determined how much I expected we would have to do to get going with a pediatric program. It turns out we don't need to find new criteria. We don't need to think about it differently. And then when we reviewed the medications, apart from a few medications, it's exactly the same except adjusted for dose. So we're very excited that our pediatric program is moving much more quickly. We have started a youth group. We will soon have a parent and care provider support group. For anybody who's interested, we have online resources at our website. And so there's lots of stuff there. And then we have our METV, our YouTube channel. So far, we have one video on pediatrics and teens, and that's Dr. Angela Grace talking about how devastating and misunderstood it can be for kids to have these conditions. With today, I can add this video and start our playlist so that we'll at least have two videos. And over the next year and more, we'll invite more experts to come and talk and increase our library. So because this is being recorded, we can't take your questions live. So if you have any questions, type them into the Q&A. So we'll give people a couple of minutes. I know we have a small group today. Give you about a minute to type in a question. If we have no questions, we'll be able to end early. Sita, you said, how can schools kids, that I don't understand the question. So accommodate kids. That's very important. And it's not just kids, but it's university students. And luckily, we live now in a day and age where there's lots of accommodations that can be had. And it will depend on a number of factors like what's the most prominent symptom, orthostatic intolerance, fatigue. But the most important thing is going to be not to gaslight the kids into thinking they're lazy or there's something wrong with them because they have to miss school. But the reality is that some kids are going to have to do school online. Any other questions? Wondering if my teen gets referred, approximately how long is the wait list to see Dr. Grace? Uh, Less than a week, because the group that we do, we are allowing people to join anytime they come in. And the group is set at 4 o'clock so that it's after school. So if your kid is referred uh, today or tomorrow, they could see Dr. Grace tomorrow afternoon at 4 o'clock. Any other questions? While we're waiting for a couple of questions, I'll talk about why, in my mind, it's been so important to have somebody like Dr. Grace. Is that in my core group, we have lots of young adults, and I can tell that the young adults are not connecting with the people who are 50. They were mid-career, they were highly successful, they had their life going, and then they were chopped down at the knees. What happens if you never got to finish school? You never got to university? Or like some of my patients, you finished medical school or law school, but you could never work because you got these conditions. And so completely different issues around dating, around relationships, around self-esteem, around identity. And that's why I feel so grateful that we have uh, Dr. Grace to help us with that. Another question is, I'm an educator and I'm wondering what could be the best way to communicate concerns if and when I notice a child might be dealing with one or more CSS, especially for long COVID, as most people in the province are living in denial. Yes. And they don't want to hear how kids might be affected. And so there's a study that showed what was the biggest impact on COVID on society. The answer, COVID amnesia. People are tired, they don't want to hear about it. And so it's tough because the best way, if you can get people, as parents, to watch two videos, family and friends, and this video, and they'll be able to identify their kids. Because if you looked at the questions that were in that screening tool for long COVID for kids, it was useless. And it didn't even ask the right questions. What about 18-year-olds? It says bow long. Oh, how long is the wait list for them for an appointment? So they can usually get in 2 to 3 weeks to see Dr. Diamond. And they can participate with Dr. Grace the following Thursday. And they can come to anything else our clinic offers, group medical visits, group medication visits, that includes their parents, as soon as they are referred. And that's why our clinic, it sounds like, quote, an innovation, really fancy. But to me, it's just makes sense. Why should you have to wait to learn? Because what we know is that the sooner you start to work on this, and a lot of the stuff does not need to be medication, the more likely you are to get into remission. So get the referral in. And tomorrow we have somebody coming, the referral's not even in. And they're going to see Dr. Grace, and the referrals are going to come next week. So we want to help you. We want to help your kids. Will a referral need to come from a pediatrician? No, a referral can come from any physician or nurse practitioner, specialist, non-specialist family physician, emerge doc, family doctor, nurse practitioner. My son is 17, turning 18 in September. He's been delayed, something with post-exertional malaise and POTS since COVID for 4 years. Should I get them referred to you now, and would they switch over to adult sessions when they turn 18? It'll depend, right? Because what you'll find interesting is that we have 30-year-olds in the youth group. Why? Because they got this when they were 16, and they're dealing with the same grief and same issues. And that's why we don't put an age limit. We look at the comments. We're going to develop more groups for kids as we move forward. We're kind of building the plane while we fly it. So it means that right now we don't have as many resources as we will have in a year, but we certainly have more than enough to get you going, especially if we can treat the MCAS, treat the POTS, find out if they're hypermobile, stop them from overexerting, get them accommodation for schools, et cetera, et cetera. So somebody said they're with Dr. Grace right now and that Dr. Grace is lovely and very friendly. Thank you. What is your take on prescribing meds for pediatric POTS? Last time I checked, BC Children's Dysautonomia Clinic only suggests lifestyle measures. So they're wrong. And if you look at the pain clinic and if you look at what clinics are doing across the world, they are using the same medication for POTS, except for one or two, and are using them at different doses. So another area where it's going to be pretty easy to to be able to help kids. There's some medications that you're not allowed to give until they're 18. And that's not because they're bad for kids under 18. It's because nobody knows. The research has never been done. But the place where you start is with salt because salt will expand your volume, your blood volume, and make your make you more able to send blood to your brain. Does the youth program include young children? I suspect my 9-year-old has long COVID. So right now it's 12 and up. And but again, it all depends on how sophisticated the 9-year-old is and if you think they would fit in. We think it's going to take us longer to collect kids under 12 because of the slide I showed at the beginning, that this really starts to be prominent in the 12 and up group. But that doesn't mean that they can't participate and get care. What is the most straightforward way to be referred? Go to our website, download the referral form, bring it to your GP. They only have to do one thing, one check mark and their signature. And that's all you need to get in to see us. It says only two of my kids got their appointments set up. Contact Bruno. Yes. And what was happening, like I said, we're building it as we were doing it. Dr. Diamond was seeing the patients and doing the full history on her own. And so there was a limited number she could see. We've just implemented our forms like for adults, which means that she'll be able to see twice as many patients starting yesterday. Will you be considering writing content, CME content for clinicians? We are, and we have. And so, for instance, Dr. McKay has just reviewed the the Canadian Society for Long COVID's continuing medical education content. I give presentations to doctors several times a year. And I probably won't be doing the PEDS ones. This is more kind of like an overview and to say, how is our clinic going to accommodate these patients? But as we develop more expertise, but just to put it in perspective for you, I did this presentation for Children's Hospital. And Children's Hospital, the tertiary hospital in the province wants to refer kids to us. That's ironic. Do you have any advice about how to deal with grandparents who say that if your kids just get up and goes outside, he will get better? Yeah. Tell them that if they continue to say that, they won't have access to the kids because they are gaslighting your kids and they are creating a sense of something being wrong with them that will last a lifetime. We have a shame and trauma group, and it's this kind of gaslighting and not being validated over a lifetime that screws people up. If the grandparents are toxic and you can't get them to shut up, they should not have any access. I know sounds pretty extreme, but I truly believe it, having seen the aftermath of gaslighting for my patients who are adults. I thought that salt is for blood pressure only. No, salt is also for POTS. Salt is the first treatment for POTS. The only individuals who should not try salt for their POTS are people who have pre-existing high blood pressure. And so somebody here, thank you, said it was very easy. Both my kids were diagnosed in 2 weeks from referral and are in the youth group. Dr. Diamond was awesome. Is BC Children's open to research so that the pain clinic and dysautonomic clinic will no longer prescribe exercise for kids? That's one of many battles that you have no idea how long it takes to change physician attitudes. And so my recommendation is to just avoid those people. Their treatment was devastating of my 12-year-old. She is now 23 and severe. Absolutely. And that's why you might have a hard time watching Dr. Grace's webinar because you can see how those kids are being screwed up by their grandparents, by their schools, by their doctors. And that's why I was being so adamant earlier about the grandparents and the gaslighting. Watch that video and you'll be convinced that you got to keep your kids away from people who are going to treat them like they're crazy. And many of my patients already know that because patients with POTS, this is a Canadian study. And I also quoted this to my cardiology friend who said that we shouldn't be seeing POTS, that 95% of women who see a cardiologist for their POTS are told that they have anxiety. Don't see a cardiologist for your POTS. Can a stress test be refused as harmful? Absolutely. You should not be doing a stress test in these kids or in adults. And because that'll cause post-exertional malaise. And so, for instance, when I worked at the Complex Chronic Diseases program, we did a study and it was an exercise test 2 days in a row. And my patient said, "Oh, should I be in this study?" I'm like, "Definitely not, because you're probably going to have post-exertional malaise lasting a long time." And out of the people that they did, it took one person a year to recover. And so they should be using non-invasive testing, which is available for the same thing. Okay, thank you so much for your patience. And I look forward to seeing your kids. And at some point, when the program is a bit more robust, we're going to open it up to children's and open it up to the general public. What non-invasive testing? In adults, we would recommend a cardiac CT. I don't know if that's available for kids, but something called a Persantine MIBI, MIBI. Thanks, everybody.